Hi everyone, I'm Dr. Deeksha Pandey, Additional Professor in the Department of Obstetrics and Gynecology, KMC Manipal, and I'm also in charge of Urogynecology subdivision in our department. I hope you all know Dr. Ruthvika. Her pessary video has gone real viral in our channel, and she has done some other case discussions also in our YouTube channel. So I'm sure that all of you know her. She needs no introduction, but still I'll tell you that she's a first year, or now you can say second year resident in our department. Yeah. Though juniors have not joined, but still we have to give them the credit that they have gone to second year. And she's going to present a case today, and this case is all cases are unfortunate when they come to urogynecology, but she is a young girl with double incontinence. So Ruthvika will present the case, then we'll go forward and do the discussion.
Yes. Thank you for the introduction. So today I'll be presenting a case of Mrs. X. She is, like ma'am said, she's a young patient, 35-year-old, a resident of Dubai. And she's a software worker by occupation. Came to her hospital with complaints of fecal incontinence since 2.5 years and stress urinary incontinence since 2.5 years. Yes, from 2.5 years she's been having these problems. And also she complains of vaginal flatulence since 2.5 years. With stress urinary incontinence, she said any slightest movement, even when she's sleeping, she has leakage of urine, and she doesn't have any sensation of urge incontinence, ma'am. No, she doesn't feel urge or increased frequency of urination, but every time she moves or she coughs, there is leakage of urine. And she also doesn't feel the sensation of bladder fullness. That also she doesn't feel. These are
this
main
is we'll
complaints.
discuss it important. This what Ruthvika told is a very important, that she doesn't know when her bladder is full. That
full.
Sensation of fullness of bladder she's not having. It has a very big implication in the history or evaluation of a patient of SUI. We'll talk about this also. Ruthvika, remind me.
Yes. And also, she has on and off burning nutrition symptoms for which she's been treated with antibiotics. Otherwise, for her main complaint, she has never visited a hospital. This is the first time she's come to us. So, in view of the symptoms starting from 2.5 years, when I went and asked what happened 2.5 years back, she told she had a forceps vaginal delivery 2.5 years ago in Dubai, and that was because of second stage arrest of labor. And the forceps was applied, and after delivery they noticed a 3rd-degree perineal tear, and the 3rd-degree perineal tear was repaired immediately then and there, and the patient was discharged. After a week, the wound had gaped, and she went to the hospital again, and they've done secondary resuturing of the wound, and after that she started experiencing these symptoms, but she never consulted anyone. Her main symptoms are vaginal flatulence. She feels like gas is passing through the vagina, and also fecal incontinence. She does not know, she passes feces without her knowledge, and also stress urinary incontinence. These 3 are her main symptoms. But otherwise, she has no other gynecological complaints, no complaints of dyspareunia. Her sexual activity is normal, no dysmenorrhea. Her menstrual cycles are also regular. No complaints of any mass per vaginum also. No complaints of mass per vaginum, and no complaints of fecal discharge through the vagina also.
So that is for rectovaginal
fistula.
So all these things, what all incontinence and whatever problem she is having, it was triggered by a vaginal delivery, which was with forceps. Okay. After that also you told very important thing, that immediately after delivery, that the episiotomy, I hope they have given episiotomy, yes. But despite episiotomy, they had diagnosed that patient was having a 3rd-degree perineal tear. For the viewer's sake, can you tell me what are the degrees of perineal tear?
Yes, so totally 4 degrees of perineal tears. The first one is just a tear involving vaginal mucosa or skin or vaginal mucosa. The 2nd-degree perineal tear is involving the mucosa and the muscle, but not involving the sphincter. That is the 2nd degree. 3rd-degree perineal tear is when the tear involves the external anal sphincter also, but external anal sphincter also, and that is
3rd degree is for external internal anal sphincter.
Anal sphincter, and in 3rd degree there are 3 types: 3A, 3B, and 3C. 3A is when the sphincter is involved less than 50%. 3B is when the sphincter is involved more than 50%, and 3C is when the sphincter is Involved completely.
Involved completely means even the internal
No.
anal sphincter is torn.
Yeah, internal anal sphincter is also torn.
And 4th degree perineal tear is?
4th degree is deficient perineal.
So 4th degree perineal means mucosa of the rectum is also torn. Anal mucosa is also torn. Okay, everything through and through vagina and anus are in direct contact. That is complete perineal tear or 4th degree perineal tear. So they have written, actually they have not, she did not know what degree, but she said that it was a 3rd degree perineal tear.
Okay. According to history.
Okay, according to her history, we did not find any documentation. Okay, so you said that perineum was repaired that time. This tear was repaired that time. So, Ruthvika, what is the best time if you identify a tear? So, what is the best? Luckily, this was a very fortunate thing that at least they diagnosed it. Many of the women will go will be discharged from the hospital without getting diagnosed, and they will develop symptoms later on. Okay. At least they did their job well. They diagnosed it and on top of that repaired it. So first tell me, how do you diagnose?
To diagnose the perineal tear, first is after episiotomy is sutured back, we have to check for the rectovaginal septum and check like the digital examination through the rectum.
Good. So this is a message what Ruthvika is telling, that for every patient, for all the obstetricians, if you are delivering any patient, never ever imagine that everything is fine. Okay, late diagnosis is as bad as missing it. Okay, so it can happen anytime. It can happen in best of the hands with 20, 25, 30 years of experience also, because everything is not doctor dependent. There can be patient factors, there can be baby related factors, there can be instrumental delivery. So whatever delivery you are conducting, as a rule, every time you cannot send the patient back to ward, or you cannot go back home until and unless you have performed a rectal examination. Okay, in rectal examination, one finger in the rectum, you have to see that anal mucosa is intact, and you have to put your thumb in the vagina to check, and preferably you should tell patient to constrict and show you whether the sphincter is she is able to constrict it or not. Okay, so you have to remember it. Now they have diagnosed that time. Now, suppose the delivery occurs. We cannot predict when a vaginal delivery will occur. Suppose the delivery occurs at, okay, tell me before that, when you are applying a forceps, it was following forceps delivery. So definitely the incidence of these kind of perineal tear is more after
forceps
instrumental delivery. And if we compare vacuum and forceps also, forceps delivery is more dangerous. But I feel that the success rate of forceps is, like, I am a person who has to choose, I'll choose forceps over ventouse. Because the success of achieving the delivery of the baby is much controlled and much more with forceps. I am a person who always goes in with forceps. But we are not telling, and we are no way we are giving this message, or anybody should percolate this message that you should not conduct forceps delivery. Likewise, you can always say that vaginal delivery increases the risk of prolapse and pelvic floor, you should stop doing. No, it is not. But in this era where we have the facility to do an immediate, very safe cesarean, you have to choose your patients very carefully. That this patient, if I apply, that wisdom should be there, that if this patient I apply forceps, I can get a good healthy baby delivered outside without much trauma to the lady. It's not that. So patient selection is very important. You have to think in your mind 5 times. And you said that forceps was applied for what?
It was applied for second stage arrest.
Second stage arrest. Yes. I can understand if the second stage fetal distress is there, then you don't have sometimes even time to think. Okay. But second stage arrest, if it was not very low head, even you could have done she could have been taken up for cesarean when fetal distress was not there. You have to weigh the risk and benefit. Sometimes it is much easy to say and discuss it here, but if you are in LT, you are standing in front of the delivering patient, and you have to take some decisions very immediately. But if we keep on thinking these things, then we are less likely to have complications. Okay. So what I wanted to tell that when you are first choosing the patient for forceps is very important. You have to diagnose correctly, and giving a good perineal support, okay, and giving a good episiotomy, liberal episiotomy is also very important. So word about episiotomy. which episiotomy would you give if you have to give episiotomy for, say, forceps or for any other? Is it medial or mediolateral?
Mediolateral.
Mediolateral always, okay? If medial episiotomy you give and it extends, it has a very high incidence of sphincter injury or sphincter involvement. So we always teach that in today's world, we always give mediolateral episiotomy. What should be the angle? You said mediolateral episiotomy, but from the midline, what should be the angle where you should cut for that mediolateral episiotomy?
So when we're giving the episiotomy, the perineum is stretched. So according to that, we give a 60-degree.
Very good. So, so it looks like that when we say mediolateral, we think that we have to cut on 45 degrees, but no.
You have to cut at the 60-degree angle, and when it actually relaxes, it comes to 45
degrees. So always this I have been seeing, and we have started studies because of that. And we see now the trend is increasing because our residents know that somebody is watching their episiotomies. So what happens when you think that mediolateral, you think in your mind that it is 45 degrees, but you have to take into consideration that fetal head is actually stretching the perineum a lot. So you have to plan your incision with your scissors at an angle of 60 degrees. When all the tissues revert back after delivery, this is the angle which is going to fall at the line of 45 degrees. So what happens if you give only at 45 degrees and when everything reverses back, it will come very close like a midline. Okay? And then in those cases, you are more likely to have a anal sphincter injury. Okay? Okay. So then you have told about episiotomy angle, you have told about forceps delivery. So when there is perineal tear, suppose you have seen, so how do you differentiate that it is a third degree perineal tear or 4th degree perineal tear? You told that if everything is through and through, then it is 4th degree. Okay, the 3rd degree, you told me 3 classification A, B and C. So external anal sphincter and internal anal sphincter. 3A, 3B is less than 50% and more than 50%. Okay. But can you tell me, Ruthvika, how do you recognize that which one is the external anal sphincter and how to differentiate what is the internal anal sphincter? On examination.
Internal anal sphincters, the muscles are longitudinal.
Very good. They come along as a sheath on top of the intestine.
Okay. And external anal sphincter with the sun ray pattern.
Sun ray pattern is there. And actually, if you imagine, a normal sphincter is like a rubber band. Okay, like a rubber band on the lower end of the intestine. Okay, so if it gets cut or torn in between, what will happen? The ends will get retracted. So what exactly you are saying? Immediate post-delivery period, maybe the sign is not that evident, but later on when you examine the patient, as you would have examined now, there is some sun drain pattern is missing from portion of the sphincter. Okay, so actually this is this rubber. The problem is not the internal sphincter, because internal sphincter fibers will remain there only. Problem is to dig into the external broken ends of external sphincter, bring them together. That's the art. Okay, to bring them together and approximate them. An approximation can be done by two methods, two techniques,
or end-to-end.
End-to-end anastomosis you can do. But the surgery fails usually when you are not able to identify them, and some people just do a mass closure. That is not enough. You have to identify the tissues and you have to approximate these tissues together. So some kind of repair. Suppose there is one junior person or a midwife who is conducting the delivery, and that person is able to diagnose. Okay, delivery happens, what we were saying, in the middle of the night, and she is able to diagnose. What is the window she has? So I'll give you what is a better option, that person herself or himself repairs that whatever knowledge she has. Is it more important, or you can wait and call some expert and experienced person to do it?
It's always better for her to wait for at least 8, like the window is 8 to 12 hours. They can wait for 8 to 12 hours. So even if it happens in the night and no one can attend, they can wait until 12 hours for an expert to come and suture it. Because the expertise matters a lot.
Yeah, so when I was getting trained in OBG, so there were so many deliveries and unattained, and we did not have much concept of later problems with OASIS. So we thought that okay, that time only mask closure is very important and we see, but it is not. You can wait. Even primary closure can be done within a window of, as you said, 8 to 12 hours. But it's better that at least an experienced person is there to guide you or identify the tissue with you. Okay, but in her it was immediately done, and patient went home, was discharged. But within how many days she had?
A week. Again, the wound had gaped. There was an infection and the wound had gaped. And then she went back to the hospital again. They've done secondary
suturing again. So again, suturing, if you are doing, then at least when we do not have any documentation, but at least that time an expert should be there, because now the cut ends of rubber band would have retracted even more. So even it is even more difficult to find out those cut ends. And I think the patient got so much fed up that she thought it was easier for her to live with the problems rather than going into hospital again and again without any relief of her symptoms and much more complication again. So can you tell me, when you do repair, suppose you have done a perfect repair, how do you want to give her post-operative care? You want to get,
So if it's for first 3 or 4 days, it is better for her to be on only liquid diet.
Very good.
Because we don't want her to
exert pressure. That will cause dehiscence of tissues.
And for the next 2-3 days, we can give her laxatives, and also teach her like pelvic floor muscle training.
Very good, pelvic floor muscle training. And we have to also tell her that how important it is to keep the area
very clean
and dry. Okay, perineal care we have to teach her, because this feces have a very important microorganism, E. coli, which infects here and there everywhere. Okay, so this care.
We tell her the technique that she has to wipe it from anterior to the posterior, and again wash her hands. Again, do it in the same way.
Yes. So this teaching is very important, because if you don't teach, many of the patients we take it for granted that they will know, but no, you have to reinforce it, teach it again. Okay. Okay, then what happened? Then for 3 years, she did not go for any physiotherapy. She did not go to any doctor. She was living with it, got healed somehow, and with secondary intention, and then she was living her bad quality of life she was having, and she was suffering for last around 2.5 years. Okay. So when she came to us, now this was about the history. Can you tell me her examination?
Yes, ma'am. So we have examined the patient full bladder. Her general condition and all that was normal, no pyloric risks, sinus edema. But on full bladder examination, there was demonstrable stress.
But she was a thin-built patient, young
thin-built patient. And on full bladder examination, there was demonstrable stress urinary incontinence.
Very good.
On coughing, there was stress urinary incontinence. And on perspeculum, there was cystocele also that was noted. And on the local examination, like I said, the sundrain pattern, it was not complete, and there was no tone. Like she was not able to constrict her sphincter, lingual sphincter. She was not able to constrict, and her perineal body was the perineal area was very thinned out.
Perineal body. So perineum is in between the posterior forehead to anterior margin of the inguinal. Usually it should be 3 to 4 centimeters of thick pyramidal structure, which measures around 3 to 4 centimeters.
But in this patient, the vaginal introitus and the anal opening were next to each other, and there was only like 1 centimeter of perineum.
Less than 1 centimeter. And if you palpated it, there was just skin. There was no, even muscle was not there, and patient could not constrict her on voluntary contraction. She could not do it. Okay, and you said one very important thing here, that she was not having even the feeling that her bladder is full. Okay, so it is very important. So maybe patient was having something we call as hypotonic bladder, and hypotonic bladder can be just a part of these injuries. So when she delivered the baby, and what was the baby weight?
I'm not exactly, around some 2.5.
So it was not a very big baby also, okay. So when the patient is telling that she is not having a sensation, so hypotonic bladder in this particular condition is most likely to be because of nerve injuries. Because all muscles, everything the forceps have or the baby has while coming down damaged, so it is very likely that even the nerves have got damaged and they have lost the sensation. Okay, sensory supply is also gone. So patient is not going to have any sensation or any urge to of full bladder or to pass urine. Now this is a very tricky point in management of stress urinary incontinence, because if you just think that patient is while change of posture she is having leakage of urine, that means actually it means a very severe grade of stress urinary incontinence. But what was happening in this particular patient, that she was, because she was not having the urge to feel, she was filling her bladder so much. Actually, she was not having, if you, so always this uniform cough stress test should be demonstrated with only around 150 to 200 ml of urine. Okay, then only you can assess the severity. It is a big learning point for us also, that because the patient was filling her bladder so much, about 1 liter, 1.5 liters urine,
She wouldn't know when
she wouldn't know. And then if you demonstrate, if you try to tell her to cough, any normal patient also with that much full bladder will leak some urine. So actually her stress urinary incontinence was not of very severe degree, but because of her loss of sensation, because of overfilling of bladder, it was giving a false. So where we would have gone wrong if we would have believed that only her history, and we would not have examined her properly, maybe thinking it is a severe urinary incontinence, we have put a retropubic tape and tight tape, which would have caused overcorrected, and she would have come with poor retention or poor stream of urine, urinary retention, multiple episodes of cystitis. Okay, so this is very important learning point from this case also. Okay.
And mild rectocele was also present.
Yes. Because everything is torn, so rectocele mild was there. But luckily this patient did not have anterior defect was there, posterior defect was there, but what was not
prolapse
there? Prolapse was not there. So luckily somehow her uterus was very much in position, and no cystocele and no enterocele, no other pelvic relaxations were not there. Okay, only functional problems were there, but anatomical defects were not that much. But you have to still teach her, because there can be occult defects lying there, which the estrogen is keeping them strong right now. But when she goes into her premenopausal and menopausal age group, she might develop those defects. So we have to start prevention now. What prevention?
Pelvic muscle training.
We have to educate her. Okay. So have you done surgery for her? She required a surgical correction. Okay, definitely it was not a case which will get cured with physiotherapy. So she definitely required a surgical correction. So what surgery you have done, Ruthvika?
So we have done a transvaginal tape obturator for her stress urinary incontinence.
I'll tell you one thing today. This is not your fault. Every student who comes to me and first initial phase, they say that is TVT means transvaginal tape. No, it is tension-free vaginal tape. You know what
I forgot.
But I'll tell you one thing which came recently to my mind, and that's why I'm so particular of using. See, I understood what you said, but every time I stop the student and correct them, well, because I think there is a lot of creativity in that. So Kulmstein and Peter Petros, when they developed this tape in 2000, like 20-25 years ago, then I think they put too much of their mind and creativity to make this word a tension-free vaginal tape, because the problem we are trying to treat is stress urinary incontinence. Stress and tension free. Okay. So that's why I actually love this creativity. I think that's what they have thought. I did not read it. I thought maybe this is the reason. That's why they did not say it any other day. To relieve that stress of the patient, whatever stress it is, they have made a tape which is tension free. So there is a lot of, when they have applied so much, we should respect it and we should percolate the same thing. Okay. So it is a tension free vaginal tape. With what approach we did? Obturator approach. Okay. Because retropubic we do usually for patients with
severe stress,
either severe urinary incontinence or if the patient is very obese. And because of technical difficulties, we prefer to put a retropubic. She was neither obese, you told, she was not having even severe
stress urinary incontinence. And then we've done perineal repair with overlap technique.
So you can call it a external sphincteroplasty also, or perineal repair also, perineorrhaphy, because perineorrhaphy usually we use the term when we do in prolapse cases, only repair of perineum. So it can be even said a sphincteroplasty. So what are the steps? How many layers you close the sphincter. Usually when we do perineuraphy, we just close the muscle and mucosa and skin. Here, how many
Here
layers?
it was 5 layers now.
Very good.
First is the mucosa, anal mucosa. Second is the
Anal mucosa, if anal mucosa is torn. Okay, in this particular patient, anal mucosa was not torn.
Then internal anal sphincter.
Internal anal sphincter is like
Longitudinal fibers.
And what suture material you use and how do you repair technique?
We take continuous sutures.
Continuous sutures with Vicryl. Vicryl 2.0 or Vicryl 3.0 is also. You don't have to put permanent suture, delayed absorbable sutures are good enough.
So
Then,
internal
internal
anal sphincter and then external anal sphincter.
So external anal sphincter, how you remember? Or you have to dig from there.
Yeah.
Okay, you have to go laterally up to the dimples,
and
then you have to dissect little bit area and pull out with the help of LS forceps. Okay. And what are the techniques to do that?
2 techniques, either overlap or end-to-end.
Which one needed?
We've done overlap.
Overlap technique. Okay. But sometimes it is not possible if it is broken too bad and you are not able to dissect. You cannot overlap.
So
then even end-to-end technique is good enough.
Yeah. Okay. Then we suture the muscles like puborectalis, the deeper muscles, and then the superficial muscles like bulbocavernous.
So puborectalis is a part of levator ani. So you put it as an extra support on the sphincter.
Then bulbocavernosus and transverse perineal muscle.
Superficial transverse perineal muscle you do. And then you close the mucosa and the we left one thing. So this is the 5-day closure perfectly you told. So that at the end of the surgery, her perineum, which was less than 1 centimeter, with layered closure, it became around 4 centimeters, around 4 centimeters. Okay. Then one thing we left, if by chance this was a very clear-cut case, and I don't think she required any investigation to prove it, but maybe sometimes for medical legal purpose, for documentation, or in case of doubt, if you have to prove that her anal sphincter is torn, do you have a test which will prove that?
You can do an endo-anal ultrasound to check the integrity of the sphincter.
Okay. So endo-anal ultrasound is a very good technique. There is a different probe. You cannot put your TVS probe because it has a piezoelectric crystals arranged in a circular pattern to take an overview. So you put that in the anal canal and then see the integrity of it. Sometimes with 3D ultrasound, if you don't have, there are many articles and we are doing one study also. Even with 3D, 4D probe, just kept on the perineum, you can see the entire integrity of the anal sphincter also. Okay, this is also a good tool. If you just have to see, suppose anatomically it looks okay. Even anal manometry will tell that the pressures will be very low when the patient is exerting or when the patient is relaxing. So that is also a way to do. But if I have to choose one test and the best test in doing an ultrasound, that is the best test to do. Okay. Then patient was surgery was done, and now patient has been discharged.
Yes, we have adjusted her tape for the stress urinary incontinence.
That we do for every patient.
And then after that, we've done an ultrasound to see her post-voidal residual volume. It was around 30 ml. And we followed her symptoms every day, every post-op day, if she could pass the urine or not, and if she was having any difficulty. Accordingly, we adjusted the tapes.
Yes. So we are not going to discuss that because in many cases we have discussed. We'll discuss what else for perineal care. You have already told, so we did like that. We gave her liquid diet for a few days and then stool softeners. Okay. And then did we give some consultation to some other department for exercise therapy? Yes. Okay. So we have pelvic floor muscle training, which is very, very important, and it will not just help her in these incontinence systems. Incontinence symptoms, but later on it will also help her to prevent prolapse. Prolapse, as we have discussed. Urinary prolapse, yes. So anything else you want to tell? So what about her? Now suppose patient goes and happily starts living her normal life. She becomes pregnant again. You said her sexual life is perfectly fine. And she comes to you and she says that you did such good management, now you deliver. How will you deliver her?
Again, we take it as an individual case and not take the
So
OASIS.
I'll ask you a direct question. Patient says, doctor, should I go for cesarean section, elective cesarean section, because last time I had so much of problem. So what will be your advice to her?
We can explain her that there is 4 to 8% chance of the anal sphincter injury
Increased
recurrence.
chance,
4
yes.
to 8% increased chance apart from
So that means that 90% of the time she will not have anything because the repair has been durable for so many years. Okay, but there is definitely an increased risk as compared to a primary patient in her for anal injury. But that does not rationalize doing cesarean for every patient. It's written in book that nicely you can give them vaginal delivery. But if you ask me, I still have reservations. I say that we have to choose patient by patient. We cannot make blanket rules. See, this patient profile we have to understand. One thing psychologically, it is in her mind that so much she has. It's not that immediately the sphincter was repaired and she was perfect. Okay, so psychological inhibition, and that will reflect at the time of her delivery. When she pushes, how she cooperates, all this will be reflected that time. Then the forceps was not applied for a fetal distress or a big baby. It was applied for a 2.5, 2.7 kg baby. So even if that baby could not come out of that pelvis, then we have to consider that point also, because every time the next baby is bigger than the first baby. So you have to keep on. At least we expect that if we give a good antenatal care, her baby should be around 2.5, 2.6. At least. Okay. So if everything is fine, then we have to consider this factor also. Okay. And we have to talk to patient, we have to make her understand, and it should be a combined decision, because in today's era, even cesarean sections are very safe. All these things we could have said that when anesthesia was not safe and painkillers were not, when antibiotics were not there. But yes, every procedure involved has some risk and have some good things. So we have to make her understand and then give the choice to the patient. We should not say that we will do this.
It's more like an individualized approach now, patient-based approach. Now we can't say cesarean is best or vaginal is best.
It depends on patient profile and what she wants. Okay. And very important thing, sometimes we start taking it to our ego. Not for this patient I'm saying. Some patient we say, okay, I can deliver you normally. Okay, or I say that other people do cesarean, I can deliver you normally. Okay, those kind of things, I think we should keep our egos. It comes in medical sciences sometimes. Okay, sometimes this competition, sometimes this ego that I can deliver any baby normally. These things, and sometimes patient only say that they think that only normal delivery is good and whatever surgery, that's not good. So you have to make it very clear that we should not bring our ego, neither the patient nor the doctor should bring their ego there, and should do what is safe for the patient. That should be our first priority. Okay.
Patient-centered approach.
Patient-centered approach. Okay. I think with this we'll stop our discussion. Thank you so much. Thank you.
Thank you.